I'm Franco Capuccio, Professor of Cardiovascular Medicine and Epidemiology at the University of Warwick, and I'm also a consultant physician running a hypertension clinic in Coventry. I'd like to talk about the importance of the early approach to your patient at the time of a diagnosis of hypertension on the basis of a few considerations. First of all, hypertension, as you probably are aware, is not a condition that is set by biology. In fact, what we have is a measure of blood pressure, which goes from low to medium to high across the population. And then over time, we draw a line and say, we define somebody having hypertension, so make a person a patient. So we start medicalizing the individuals on the basis of a cutoff point that, as you know, is decided and moved according to evidence and health economics in order to dispense drug therapy and try to prevent the risk at that level. But in principle, as you probably know, most of your patients will come to you at a time where you will measure the blood pressure, maybe for other reasons. The person will be completely symptomless and will be healthy, and younger, as you know, as we go along with greater incidence at younger age. And yet you will tell somebody who is normal, who has no symptoms and no particular illness or complication, that he or she will have to take tablets for the rest of their lives. This is something which is not in the normal paradigm of medicine. Although it applies to more than one aspect, it's not just hypertension, I think it will raise a couple of considerations. We know that obviously it is a concept that needs to be given to the patients we diagnose as hypertensive, that they'll have to continue for their lives taking their tablets. And we know that concordance is one of the major issues, and lack of concordance, one of the major problems we have at the moment in trying to sustain the protection of drug therapy in somebody's lives. So I think it's very important that we establish early on a good relation with the patient and a sort of virtual contract whereby your advice and the trust between you and the patient will be delivered to your patients, who eventually has to, let's say, be concordant with your recommendations. And I think one of the major aspects is to make them understand what is the reason for needing to take tablets before they develop disease. Obviously, one of the aspects is that we are treating a risk factor, which is the major cause of further illness and perhaps premature consequences, very often irreversible. Let's think about a premature stroke, non-fatal stroke, that may leave disabilities. We may think about a heart attack, which of course may not be fatal anymore, but may leave limitations in their lives that definitely are not reversible back to normal. So at that stage, it may be a very powerful motivation for the patient to understand that the way they take their tablets is like the way of paying an insurance premium that will be paid off later on. The next is make sure that the tablets you eventually settle the patient on will be very effective in reaching targets, will be absolutely well tolerated with no side effects. So I think the first stage is unusual, and we should make an effort to make sure that patients do understand the reason why they should take tablets and feeling well. And one of the aspects that I tend to suggest that we're treating somebody to prolong well-being rather than to prevent disease.
My name is Brian Williams. I'm a Professor of Medicine at University College London Hospitals in London. So guidelines are used to help doctors decide when to treat people with high blood pressure. Actually, in hypertension or high blood pressure, we have more data from clinical studies and observational studies that have taken place across the world for many years than almost any other clinical condition. So our decisions about when to treat patients are really grounded in quite solid evidence. What we say to our doctors about the treatment of high blood pressure is that we should consider treating anybody whose blood pressure is consistently above 160 systolic that's the high number, or 100 diastolic, which is the lower level to which your blood pressure falls. And so this would require treatment normally with drugs, but at the same time also consider using lifestyle measures, particularly making sure your weight is in the right range and reducing your salt intake in your food and avoiding excessive amounts of alcohol, but drinking within normal limits is perfectly acceptable. It shouldn't affect your blood pressure. Now, in terms of if you do go on treatment, how low should we lower the blood pressure? Well, ideally we'd like to get the blood pressure below 140/90 in the majority of people with high blood pressure. Now, I said that we would treat high blood pressure if it was above 160/100. But the issue is we also treat some people with a lower level of blood pressure, and that's so-called stage 1 hypertension, when blood pressure is 140 or more, or 90 or more for the diastolic. Now, in those patients, we would consider treating them if not only they had high blood pressure, but some other condition that might increase their risk of heart disease or stroke, such as if they're diabetic, if they have kidney disease, if they've already had a heart attack or a stroke, or if they've got any other evidence of vascular disease, we would treat at a lower level of blood pressure, that's 140/90. Finally, I would say that in terms of the very elderly, and that's defined in guidelines as over the age of 80, we're more relaxed at the level of blood pressure at which we would start treatment, and that is 160 systolic, the top number. If your blood pressure is above 160 and you're 80 years of age or more and you haven't yet been treated, it would still be worth considering treatment, as we know it will reduce the risk of stroke. So they're the levels of blood pressure which we treat. In terms of treatment itself, the drugs, that's become much easier. We use 3 or 4 major groups of drugs. There are very clear guidelines to the doctors about how to use these drugs. And if we use these drugs effectively, they're very well tolerated in most patients and control most patients' blood pressure very effectively.
My name is Dr. Adrian Brady. I'm a consultant cardiologist in Glasgow, an associate professor and president-elect of the British Hypertension Society. So hypertension in the heart, in really just a few words, hypertension drives left ventricular hypertrophy, which we all know. It drives atrial fibrillation. It leads to coronary heart disease and heart attacks, and it leads to heart failure. And these are the cornerstones in my mind when I'm thinking about treating individual patients with hypertension. I think if I leave them untreated, that's at risk of an MI, heart failure later, particularly in women, and atrial fibrillation for many. And so those are the real cornerstones, apart from stroke, for treating hypertension in an otherwise well individual. Will reduce stroke by at least 50%, and will reduce coronary events perhaps by as much as 40%, and heart failure substantially as well. So these are really the little vignettes of thought in my mind when I'm seeing an individual with high blood pressure and explaining why I'm going to treat their blood pressure. They say, well, what difference does it matter? It's to lower blood pressure, to reduce stroke first and foremost, and secondly to reduce the cardiac long-term sequelae, which are heart failure, myocardial infarction, atrial fibrillation. Renal function will be discussed by other members. Is there any particular drug which is much better than others? Well, there have been meta-analyses that have come and gone over the years. The key thing is to lower blood pressure. Which drug that we choose or which combination of drugs, the British Hypertension Society, nice guidance, the current one, gives us exactly the pathway which we should choose. What about hypertension among patients with established coronary heart disease? Well, for these people who have angina and hypertension, then beta blockers are our first choice. We know they lower blood pressure, they reduce plasma renin, plus they reduce slightly the risk of myocardial infarction, and certainly in people with previous MI, they reduce the risk of reinfarction and of sudden cardiac death. So beta blockers are our first choice, and then above that, we really add drugs, usually an ACE inhibitor next, and then diuretics as required. Heart failure, we've got abundant evidence for ACE inhibitors and angiotensin receptor blockers as first-line therapy. Quickly be adding beta blockers, quickly be adding mineralocorticoid receptor antagonists, for example, spironolactone, or perhaps eplerenone, and then into the more esoteric side of cardiology with resynchronization therapy for these people with hypertension, heart failure. Hypertension, funnily enough, if you have heart failure, to have a maintained blood pressure is quite a good sign. And so if somebody has the blood pressure 140/80, and has heart failure. In fact, that's a better sign than somebody who has a blood pressure of 90 over 60. So that's a useful thing to remember, that to have a little bit of blood pressure if you have heart failure is a good thing.
I'm Graham McGregor, Professor of Cardiovascular Medicine at the Wolfson Institute, Barts Hospital. I'm going to be talking about the importance of salt in raising blood pressure. Now, the reason why we're interested in this is that blood pressure is the single biggest cause of death in the world, because it's the major factor that causes strokes, heart attacks, heart failure, renal disease, and salt is the major factor that puts up blood pressure. Now, you as doctors, or even as individuals on treatment, may think that the important thing is to control high blood pressure. That's when the systolic's above 140. But in fact, the risk starts of systolic pressure against stroke at 115. That's 80% of the population in the UK. So we're nearly all of us at risk from our blood pressure. Now, obviously, we're not going to treat all these people from 115 to 140 because the risk is low, much more exposed. So the number of strokes occurring are about the same in the two groups. That is, the people with upper limit of normal blood pressure and those above. So we want to treat blood pressure and seek them out, but we also want to adopt population measures to lower blood pressure. And that's where salt comes in, because salt is the major factor that puts up blood pressure. Now, when you look at salt in the UK population, most of the salt we eat is already added by the food industry. About 80% comes from the food industry, only 15% is added by the consumer, and 5% is naturally present in the food. So we have a big problem, because clearly we need to get the industry to reduce it, but actually that's a very attractive problem, because it's much easier to get the industry to reduce it than it is to persuade people to reduce their own salt intake, which requires a lot of knowledge. And what we've done in the UK is, by talking to the industry and also a very good agency, the Food Standards Agency, was to come up with a plan in the early 2000s about how to reduce salt intake. And that was, what we did was set targets for each food group. So bread is the biggest source of salt in the UK diet, and we set targets for that to be achieved in 4 years. Cereals, there were in fact 86 categories of food, so it's a huge number to go through. And all of them had targets that the food industry had to achieve in 4 years. Then, after 2 years, we then reset the targets with a further reduction down, and then you reset them again. So in other words, you're gradually screwing them down, getting more and more salt out, but actually each time it seems quite small. Now, the beauty of that is that you probably won't have realised that every product you buy in the supermarket has been reduced in its salt concentration by around 30 to 40%. Without you even realising. And you can go on buying the same products, your salt intake's fallen, blood pressure's fallen. And we've documented that. There has been a reduction in salt intake in the UK. There has been a fall in average population blood pressure. And this will cause around 9,000 stroke and heart attack deaths a year less. So you see the benefits of that. Now, that policy is ongoing. We've spread it out to the rest of the world. So most countries in the world now are either adopting a similar plan to the UK, or where salt is added by the consumer, public health campaigns. So for once, it's a big success story for the UK. We led the world on salt reduction. It's been copied all over the world. And I think it's important that you get that message across to individuals and your patients, or if you're a patient with high blood pressure, because actually reducing your own salt intake is very effective as well. But this is a population reduction. So that's how we did it.
I'm Franco Capuccio, Professor of Cardiovascular Medicine and Epidemiology at the University of Warwick. And I'm also a consultant physician running a hypertension clinic in Coventry. I'd like to talk to you about one aspect that's very important in hypertension prevention and management, and that is the importance of salt and the way we manage the level of salt we eat. And salt is a major component of our daily diet, and is an essential component of our nutrition. However, the amount of salt we need for our body to function properly is a fraction of the salt we currently eat in our daily diet, almost about 10 to 15, 20 times higher than we should eat. And that has been clearly shown to be one of the major determinants of high blood pressure in our populations, in our individuals, and also a reduction has been clearly shown to be of great benefit to individuals and populations in trying to manage their blood pressure and to reduce the use of medications if they have high blood pressure. Now, salt comes mainly in our diet historically from the need for refrigeration, salt in our diet enters through the history when we did not have refrigeration yet and we had to keep the food from rotting. But now, in a new era, the amount of salt that comes in our diet is due to different purposes and mainly is added by industry in the processing, manufacturing of food and could be avoided. Now, for those who don't know, about 3/4 of the salt we eat comes from salt added to our food by somebody else. Only 1/4 of the salt we eat is decided by us using the salt cellar or adding salt to cooking. So it's very important that we address the potential reduction in salt intake as a way of reducing blood pressure in 2 ways. One is by improving the awareness of people like you and me that salt is bad for you and should not use it in your cooking, as normal food will guarantee the amount of salt you need for the body to function. So no way of adding salt to food and cooking will be the first way to do it. If you're concerned about taste, the taste will adjust within 4 to 6 weeks and you will get used to having a lower salt content food and enjoy the food in different ways. But the most important thing is that that would not be enough to reduce the salt we eat currently to a level which is safe. At the moment are set around 5 to 6 grams of salt per day, which at the moment is about at least half of what we eat currently. So how do we achieve that? The next level is really to try and avoid the very salty food present in the supermarket on the shelves, whilst there is an action at public health level to encourage the industry to reformulate the food with less salt in it. But what is left to you in terms of choice is to try to identify salt at a very early stage before you buy your food. Now, it's very difficult to do so because labeling is still quite complex. And I think organizations like CASH with the government and the MRC have developed, for instance, in Britain, a very helpful app that you can download freely called Food Switch, which exactly empowers patients like you to identify and understand the labeling of food at the point of purchase. In other words, you can download this app with a camera, you scan your barcode, and the app will tell you in a very simple and understandable way all the content in salt, fat, energy that item has to empower you to choose whether or not it's worth buying it. So from the point of view of doctors, again, it is very important that the question of how much salt your patient eats should be part of your routine approach. I'm very conscious that in 7 minutes in primary care it's very difficult to pack everything in, but a much greater dissemination of information within your practice will be the very, very first step to make patients aware and alerted about the importance of reducing salt in their diet. If you were to invest a bit more resources to assess individuals' salt intake in order to make a motivation to reduction with a way of monitoring their success, we would recommend carrying out a 24-hour urine collection whereby you can assess the individual's salt intake by measuring the excretion of sodium in the last 24 hours. So by and large, I think this is to motivate people like you and me in terms of patients, doctors, to increase awareness and act to reduce the salt content and the salt consumption in patients as well as people as a first step to tackle the prevention and management of hypertension.
I'm Graham McGregor, Professor of Cardiovascular Medicine at the Wolfson Institute, Barts Hospital. Well, I'm going to be talking about how you, as an individual or your family, could reduce salt intake. Now, that actually is quite difficult because it requires knowledge of where the salt is in your food. And for most people in the UK, 80% of the salt we eat is already hidden in the food, in bread, cereals, ready prepared meals, when you go out and eat and so on. And it's not the salt you add in your cooking or at the table, although some people do add a lot and can obviously stop that. But I can tell you, in terms of patients with high blood pressure, we were very successful in reducing salt intake because we had the knowledge to inform them how to do it. Firstly, you must stop adding any salt to your food or any things that contain salt, like stock cubes, soya sauce, all those sort of things, in the dustbin, right? That's what you need to do. That's the first step. The second step is to think about the sort of foods you're buying and can you change them to foods that have less salt in. And this does mean avoiding a lot of highly salted processed foods. And if you can, making your own things with either far less salt or no salt at all. As I said, bread is the biggest source of salt in the UK diet. If you can find breads with less salt in, they are labelled, some of them, but not the ones that are baked fresh. Or ideally, make your own bread, which is great, and you can make it without salt, very easy. You just try without salt, you'll find it make delicious bread. The only problem with that is it dries out very quickly. So what you do is you slice it as soon as it's baked, put it in the deep freeze, take it out, slice by slice, put it in the toaster, and it is fantastic bread, really, really nice toast, beautiful. So that's one thing. That will get your salt intake down, if you're a bread eater, by at least 2 grams a day. Remember, we eat about 8 grams a day. So we want to get it down by about half. The next thing is think about other processed foods. Do you have things like cheese, ham, meat products, very high in salt? Can you do your own cooking and so on, trying to avoid homemade, the manufactured soups, the dried soups? Anything like that will help. And when you eat out, try to go to restaurants where there's a chef who will give you meals with less salt. And you should be very proactive about this. That's what I do. I say, look, I've got high blood pressure. I'm on treatment with high blood pressure. I don't eat salt. Can you cook a meal with less salt? Don't say no salt, but with just as good food. And very often they will. Surprising now, many chefs now will do that, and we have many celebrity chefs backing our campaign who guarantee that in their restaurant they will give you food with much less salt in it. So getting the knowledge and getting how to read the labels, and for those that have signpost labeling it's quite easy, but it's in grams of salt per 100 grams and then grams of salt per serving. And remember, a very good thing to tell you how much salt is in a product is compare it to Atlantic seawater, because very conveniently Atlantic seawater has 1 gram of sodium per 100 grams or 2.5 grams of salt. So if you see the label saying, you know, this soup has 2.5 grams of salt per 100 grams, that is the same concentration as seawater. And that allows you to see just how much salt is stuffed into foods and allows you to decide which foods you're going to eat or not. It is difficult, but one of the great things is that the salt taste receptors adjust. The sensitivity of them depends on your chronic salt intake. So if you lower your salt intake, initially the food tastes quite bland, and we say to people, you just go through that, and then after 3 to 4 weeks the salt taste receptors become much more sensitive, and you can then really appreciate fresh meat, fresh fish. You can tell which meat it is, how good the vegetables are, and you can cook fantastic food with all the spices and garlic and onion, and if you want to, adding wine or all those sort of things. You can make fantastic food that really tastes so much better. And if you cut out the saturated fat as well, cut out the sugar, and concentrating on eating more fruit and vegetables, you'll feel much better. You feel much more energetic. This high fat, high sugar thing makes you like this. And if you get onto a healthy diet, not only will it lower blood pressure, but you'll feel better, it will lower your cholesterol and get good control of your weight. So that's what I advise you to do. A really healthy diet, and you'll live fantastically, you'll feel well, and you'll live longer. So why don't you do it?
My name's
No.
Kennedy Cruikshank. I'm Professor of Cardiovascular Medicine and Diabetes at King's College London at Guy's and St Thomas's Hospitals. I'd like now to talk about different ethnic groups. People of West African origin, whether directly from West Africa or of Caribbean origin and African descent, and of course African Americans, where much of our evidence comes from, have been thought to respond more poorly to drugs such as beta blockers and ACE inhibitors. And there is a smaller reduction in blood pressure. But there is a reduction in blood pressure of these agents. They're just not first choice for the first line of treatment. Combined, diuretics and ACE inhibitors, diuretics on top of ACE inhibitor calcium antagonist combinations do very well.
My name is Jane Deal. I'm a paediatric nephrologist with an interest in hypertension in children and adolescents. Hypertension in the young is still relatively rare, but is important for the individual child, but perhaps more importantly for the future adult. We are seeing an increase in hypertension in the young, mainly associated with the increasing levels of obesity, and as a result there's a time bomb in this country and the Western world that's going to lead to substantially increased prevalences of hypertension, both while they're young and as adults. It's complicated in the young. The origins of hypertension date from fetal life and are there in childhood, and we need to be doing something about it. It used to be said that the majority of cases in the young was due to secondary hypertension, and therefore it's important that investigations thoroughly look into the underlying cause, and then treatment is guided by what is found. But increasingly we're now finding that primary hypertension is much commoner than used to occur, and the interventions for that are more contentious and perhaps more importantly very tricky to institute. Because of the association between hypertension and obesity, it's going to be extremely important to tackle the epidemic that we're seeing, particularly with non-pharmacological measures, weight reduction, salt reduction, increased exercise, and avoiding other risk factors such as smoking. But these are also the areas that are most difficult to have an impact, particularly in the young who are notoriously resistant to the measures that are introduced. In terms of what a GP should know about hypertension in children is they should know that it exists, it's silent, therefore if you don't look for it you won't find it. Conversely, screening probably has no place because we don't know what the long-term benefit of screening is yet, and most of the studies show that it hasn't got a place. GPs need to know how to measure blood pressure in the young, and that relies on having the right equipment and the knowledge of what is normal, which means getting out the centile charts that have been derived so that the measured blood pressure can be compared, knowing the age, sex, height of the child that's being measured. Having the right equipment is extremely important. Many of the machines that are out there and available are not validated for use in children. And so it's very important to check, particularly on the BHS website, to make sure that any machinery that is being bought is appropriate for use in children. Having the right size cuffs is extremely important, and having the right environment and the time to be able to measure the blood pressure in a relaxed, non-stressful situation is very important. What should a secondary care physician know? Well, really much the same. The importance of measuring blood pressure in the young, getting sensible readings, taking note of those readings, and having some understanding of the underlying epidemiology and investigating the young people.
I'm a consultant at the Bart's Blood Pressure Centre of Excellence at St Bartholomew's Hospital in London, and I'm going to talk for a few minutes about the importance of dietary modifications in blood pressure and hypertension. So control of blood pressure is one of the most important ways that patients and the general public can control their risk of heart attacks, strokes, and kidney failure. And there are two strategies to control blood pressure. One is by the use of medications that will be prescribed by general practitioners and specialists. But the other track is the lifestyle modification that patients can do themselves. This is particularly important because not everyone's aware that they have high blood pressure. And we know that the awareness of blood pressure in the UK is increasing year by year, but it's still not perfect. Now, if you read the mainstream press or magazines, it's very easy to be confused about the advice we're given about what type of dietary patterns we should follow. One day you'll read that having a high-fat and low-carbohydrate diet is correct, and when you read something the next week, you'll hear about antioxidants and superfoods, and that protein is good. There are some clear recommendations to dietary modifications to lower blood pressure and cardiovascular risk that we advise in the UK. One of the most important is the reduction in the amount of salt we consume. And the UK government has been working very hard with the food agencies and the food producers to show that salt labelling on foods is clearer, using the traffic light system so that we know that if we're looking at labels that are red or amber in colour, they have very high salt content. So we should be trying to eat more foods that naturally are of the green traffic light system, which shows that they are low in salt. Another area of dietary modification that's important is the amount of sweetened beverages we have. There's increasing evidence that carbonated fizzy drinks that have added sugar are associated with increasing levels of blood pressure. And those are things that we should try to avoid, but I'd like to spend the rest of my time talking about what things we could do actively and what types of foods we should be eating. And one of the most important things is that it's important to have a varied diet. In particular, having a varied amounts of fruit and vegetables in our diet has been shown to lower blood pressure and is associated with smaller risks of having a heart attack or stroke. Foods that seem to be particularly good at lowering blood pressure and cardiovascular risk are green leafy vegetables, such as salads, spinach, rocket, beetroots that grow with green leaves. And these have been shown in studies to reduce blood pressure and reduce the chance of having heart attacks and strokes. Now, it's not entirely clear at the moment what it is in the vegetables that's beneficial. Vegetables have lots of good things in them, such as fibre, potassium, dietary nitrates. But to some degree, it doesn't really matter what the beneficial component is, as long as we're actually consuming those vegetables in the first place. A varied diet would also include components that come from the Mediterranean diet. We know that countries that border the Mediterranean, which have high fruit and plant-based oil contents compared to animal fats, as well as lots of fresh vegetables and high levels of oily fish, also have lower risks of heart disease and strokes. So combining a high fruit and vegetable diet with possibly having more plant oils, such as olive oil or rapeseed oil, which you can get in the UK very easily, and trying to keep a low saturated fat diet are probably the most prudent ways that we can lower our blood pressure and cardiovascular.
My name is Kennedy Cruikshank. I'm Professor of Cardiovascular Medicine and Diabetes at King's College London at Guy's and St Thomas's Hospitals. Now, my final discussion is about what we might call blood pressure variability, how much your blood pressure goes up and down between visits or even at home. We now know is a very important indicator of future damage to your arteries. Now, if you can control that variability, it makes a great difference. And once again, calcium antagonists seem to be best at that. They reduce the amount that variability happens. And it's probably because they're also very useful for a new concept in high blood pressure work, which is how stiff your arteries are. Lay people have talked about hardening of the arteries for years. Getting doctors to understand it is rather more complicated. But if you get the idea that stiff arteries respond better to combination agents and possibly also to a salt-losing drug called spironolactone, then these will likely play a part in the future.
I'm Franco Capuccio, Professor of Cardiovascular Medicine and Epidemiology at the University of Warwick, and I'm also a consultant physician running a hypertension clinic in Coventry. Hypertension is a common problem in our country and affects all groups of the population, from young to middle age to old, from men to women. But one aspect I want to address is, in a modern society which is far more diverse as time goes, is the variation in the risk of having hypertension and the opportunities we have for different detection and control in groups of different ethnic background. In Britain, at the moment, the latest census, we have over 6 million people that are defined born outside the UK or from different ethnic background, which makes more than 12% of our population. These groups are not evenly distributed around the country, but they usually cluster around large areas of large cities like London, Manchester, Birmingham, the West Midlands and so forth. So that maybe for some of you listening to me would be less of a problem than for others. When I say a problem, less of a daily clinical challenge in dealing with patients that come from such a diverse areas of the world. Why are we concerned about that? Why are we discussing this? It's because these groups, by and large, have the same sort of progression of hypertension and may respond similarly to other groups. But there are some specific areas in which they differ in terms of risk factors, clinical development, and also response to drug therapy. Now, the largest groups, the more represented groups in the UK are those that we classify from the Indian subcontinent of South Asian origin, and there would be Indians, Pakistani, Bangladeshi, who moved to the country in the early 60s and 70s, and now we have second and third generations. And also the other large group is the group that we define as of Caribbean origin or of African origin, again also reflecting waves of immigration in the 60s from the Caribbean and more recently from Africa. Now these two groups have some characteristics that deserve some attention. As far as the people of the African origin, whether they are from West Africa, East Africa or the Caribbean, do suffer from hypertension very often, very commonly, even in their own country. And we know that their hypertension appears to be of early onset, very often, so at an early age, and also may develop more severely. Now, there have been arguments of whether that is a genetic aspect or whether in part may reflect socioeconomic influences on the disadvantaged group. But that, irrespective of that, there are some aspects that are physiological. People of West African origin and from the Caribbean, in fact, do have a low level of one hormone called renin, which determines a different sensitivity of their body and their vasculature to the effects of a number of triggers like high salt intake. For instance, for the same level of salt intake, their response is much bigger than compared to other counterparts of white European origin. So they will benefit more from a reduction in salt intake in terms of blood pressure reduction, as well as they can have more damage if they eat more salt. Likewise, for the same mechanism, some of the responses to drug therapy may vary in these groups. And in fact, in part, the British Hypertension Society NICE joint guidelines do acknowledge in their algorithm this characteristic, by suggesting, particularly for monotherapy, that people of African origin might well respond better as a monotherapy to either a calcium channel blocker or a diuretic, and that's mainly on the acknowledgement of their condition of being a low renin individuals. Likewise, the outcomes in these groups may vary epidemiologically from those of the white counterpart group. They're more prone to develop strokes as a result of high blood pressure, and their strokes are more likely to be of a different nature, being so-called lacunar or small vessel disease strokes, rather than due to occlusion of the large arteries. And that has been established quite clearly about the South London Register that's been looking at that in great detail in the last 20 years. Likewise, for the same mechanism of small vessel disease, the kidneys appear to be a primary target of the hypertension in people of African and Caribbean origin, more prone to developing chronic kidney disease. So some attention should be paid to the ethnic origin of these patients and to the both preventive and therapeutic approach to their management. The other major group of South Asians do have some other characteristics that make them unique in terms of managing the overall cardiovascular risk profile. People of South Asian origin, like Indians and Pakistani, do have a greater propensity to development of type 2 diabetes or of metabolic abnormalities of glucose intolerance and insulin resistance, which very often are associated with central obesity. Their prevalence of hypertension is not particularly different from that of our British white counterpart. However, the way the complications develop as a result of blood pressure jointly with the comorbidities I've just mentioned make the prevention of complications and the management of their hypertensions slightly more challenging. In particular, they will develop more of the diabetic hypertension complications, which will focus both on the nephropathy and on the retinopathy. And it's particularly important to be more aggressive in their blood pressure control, particularly in the presence of metabolic abnormalities, as that comorbidity will make blood pressure more difficult to control. In terms of types of blood pressure classes they respond to, they will not differ of any greater extent from those that we would use in a non-Indian white counterpart. And finally, there is an issue of lifestyle factors. Most of these factors for both groups do in part find some origins or some triggers or some risks in the related behaviors they take from their original culture. Dietary aspects in Afro-Caribbeans, we know, do contain high levels of salt in their traditions, and that should be tackled with greater awareness and more preventive strategies to reduce the salt intake in people of African origin and the Caribbean. And likewise, in terms of the South Asian groups, there have been many initiatives in this country and should continue to do so in order to make them aware of the risks, for instance, of having very large amount of animal fat, including their diet, and also just to replace them with more vegetable oils or less monounsaturated fat in their cooking, which will reduce the amount of metabolic burden.
Hello, my name is Richard McManus. I'm a GP in Oxford and Professor of Primary Care Research there as well. And I'm going to talk to you in this short clip about self-monitoring of blood pressure. Self-monitoring of blood pressure, like any other kind of blood pressure monitoring, depends on the equipment that you use, and would always recommend that you use a validated monitor. These can be found, a list of these can be found on the BHS website and are now available from around the £10 to £15 mark, so really very cheap, so most people can afford them. Having picked a monitor that is validated, then the next thing to make sure is that you have a cuff size that you're using for the monitor that's correct, and it's important to make sure that the circumference of your arm and the cuff size match. Otherwise, you can either underestimate blood pressure if your cuff is too big or overestimate if it's too small. In general, for monitoring at home, we recommend that people do at least 2 readings in the morning and 2 readings in the evening for a minimum of about 4 days. Often the first day, blood pressure is a bit higher than subsequent days as one gets used to monitoring, and so it may be that you need to disregard that. We know that around 30 to 40% of people with hypertension in primary care are currently self-monitoring, but interestingly, only about half of people actually ever tell their doctor. So if you're a physician or a GP, ask your patients, and if you're a patient, really think about telling your doctor that this is what you're doing. They should be interested, and if they're not interested, I would argue that you should quiz them as to why that is, because self-monitoring of blood pressure can give very important information. The normal level of blood pressure measured at home is slightly lower than typically measured in the clinic. So for a clinic reading of 140/90, we'd estimate that a home reading of 135/85 is roughly equivalent. So that's important to bear in mind. And about half of GPs in surveys that we've done don't actually take that into account. So that's something to perhaps remember. If you have diabetes or heart disease or a previous stroke, it may be that you need a slightly lower target than the standard 140/90, in which case discuss that with your doctor. Overall, we know that self-monitoring can detect those people whose blood pressure is high in the clinic but normal at home, for whom prognosis is very similar to those without high blood pressure. But importantly, it'll also detect blood pressure that's high at home but normal in the clinic, so-called masked hypertensives, who have a worse prognosis than otherwise expected. So that's my quick overview of self-monitoring. The key points to remember are: use a validated monitor with a correct cuff, tell your doctor, ask your patient, and monitor for at least 4 days. Thank you very much.
My name is Brian Williams. I'm a Professor of Medicine at University College London Hospitals in London. So guidelines are used to help doctors decide when to treat people with high blood pressure. Actually, in hypertension or high blood pressure, we have more data from clinical studies and observational studies that have taken place across the world for many years than almost any other clinical condition. So our decisions about when to treat patients are really grounded in quite solid evidence. What we say to our doctors about the treatment of high blood pressure is that we should consider treating anybody whose blood pressure is consistently above 160 systolic, that's the high number, or 100 diastolic, which is the lower level to which your blood pressure falls. And so this would require treatment normally with drugs, but at the same time also consider using lifestyle measures, particularly making sure your weight is in the right range and reducing your salt intake in your food and avoiding excessive amounts of alcohol, but drinking within normal limits is perfectly acceptable. It shouldn't affect your blood pressure. Now, in terms of if you do go on treatment, how low should we lower the blood pressure? Well, ideally we'd like to get the blood pressure below 140/90 in the majority of people with high blood pressure. Now, I said that we would treat high blood pressure if it was above 160/100. But the issue is we also treat some people with a lower level of blood pressure, and that's so-called stage 1 hypertension, when blood pressure is 140 or more, or 90 or more for the diastolic. Now, in those patients, we would consider treating them if not only they had high blood pressure, but some other condition that might increase their risk of heart disease or stroke, such as if they're diabetic, if they have kidney disease, if they've already had a heart attack or a stroke, or if they've got any other evidence of vascular disease, we would treat at a lower level of blood pressure, that's 140/90. Finally, I would say that in terms of the very elderly, and that's defined in guidelines as over the age of 80, we're more relaxed at the level of blood pressure at which we would start treatment, and that is 160 systolic, the top number. If your blood pressure is above 160 and you're 80 years of age or more and you haven't yet been treated, it would still be worth considering treatment, as we know it will reduce the risk of stroke. So they're the levels of blood pressure at which we treat. In terms of treatment itself, the drugs, that's become much easier. We use 3 or 4 major groups of drugs. There are very clear guidelines to the doctors about how to use these drugs. And if we use these drugs effectively, they're very well tolerated in most patients and control most patients' blood pressure very effectively.
My name is Vikas Kapil. I'm a consultant at the Barts Centre of Excellence for Blood Pressure at St Bartholomew's Hospital in London. And I'm going to talk today about the importance of combination therapy in the treatment of high blood pressure. So we know that in the UK, control of blood pressure is not perfect in all patients. Only about 50 to 60% of all patients treated for their blood pressure achieve adequate blood pressure control. Now, there are lots of reasons for this, but one of them is potentially the fact that patients aren't being given early enough in their blood pressure journey combinations of medicines that are known to lower blood pressure effectively. And combination therapy is potentially beneficial for several reasons. One is that we know combining medicines at lower doses is better for blood pressure control in terms of the magnitude of blood pressure reduction than increasing a single medicine on its own. So if you take 2 medicines at a very low dose, you'll get more bang for your buck in terms of blood pressure reduction than if you increase either of those medicines on their own to a much higher dose. Another reason that combination therapy is potentially very useful is that although most medicines taken for blood pressure are very well tolerated by most patients, some patients do develop adverse drug reactions and side effects. Taking medicines at lower doses in combination means that most patients will avoid any possible side effects, because side effects are dose related. So the more of a single medicine you take, the more likely you are to suffer a side effect, or the more serious that side effect might be. Increasingly, in the UK and in Europe, when patients have very high blood pressure to start with at diagnosis, there's a move to using at least 2 medicines to start with in combination to lower blood pressure, because we know that for the average person with mild hypertension, a single medicine lowers blood pressure by about 9/5. And so if blood pressure is much higher than ideal, combination therapy will be needed eventually. Trials are ongoing, sponsored in part by the British Hypertension Society, to find out whether starting in all patients with 2 medicines is better than 1. And these trials should be reporting very shortly. Thank you.
I'm Franco Capuccio, Professor of Cardiovascular Medicine and Epidemiology at the University of Warwick, and I'm also a consultant physician running a hypertension clinic in Coventry. I want to talk to you about one of the emerging aspects in the clinical practice of hypertension, and then the importance of sleep disturbances in assessing the risk of hypertension and also the consequences and the prevention of complications in patients who do suffer from sleep problems alongside high blood pressure. We all sleep, and this is a part of our life. In fact, we spend a third of our life asleep, and yet very little has been done until recently to investigate what happens when we have problems with our sleep. Sleep disturbances of quality and quantity, in other words, how well you sleep and how much you sleep, have become an increasing problem in a modern society, leading mainly to the pressure of the 24/7 society, asking us to pack more in our daily life and basically trading off our single more precious time, which is the time we spend asleep. And there is quite a great concern that over the last 100 years, we have collectively around the world lost more than 2 hours of sleep per night on average, which is a lot. So the epidemiology of sleep disturbances, first of all, tend to suggest that the less we sleep, the more likely we are to develop short-term problems and conditions of which we are all aware of. You always had a bad night's sleep, and the following day you are tired, you lack concentration, you may want to catch up on sleep. That's what we call short-term consequences, which in general are temporary as long as your sleep reduction is temporary. But more recently, the problem of sustained, prolonged sleep deprivation is becoming a problem. And that has been clearly associated with the long-lasting consequences, among which some are very relevant to cardiovascular disease. In other words, if you have a sustained sleep loss, let's say over less than 5 hours per night on a sustained time, you tend to develop obesity more often, you're more likely to develop type 2 diabetes, you develop more hypertension. You know how important hypertension is, for instance, at night, where you tend to reduce nocturnal dip and then increasing the risk of cardiovascular. And indeed, when you look at the effect on strokes, heart attacks, you find an increased risk of developing a stroke or a heart attack. So these are real problems that all become important now. How do we deal with that in practice? It's very difficult at the moment to have any tools that may prolong your sleeping time unless we act on the environment that allows us really to sacrifice our sleeping time. But there are a few tips that in practice we should learn. First of all, how many of you on a routine assessment of your patient tend to ask about the amount of sleep and the quality of sleep? We do ask about smoking, a level of exercise, maybe level of salt intake, but it's hardly anyone still concerned about sleep. And I think it is time that really we are proactive in probing patients to find out whether they have sleep disturbances, which could be the first hint into exploring the risk of cardiovascular events. The commonest problem in clinical medicine, however, is a condition which is becoming far more prevalent because it's more diagnosed, in fact, and that is the presence of obstructive sleep apnea syndrome. That is a condition that's been known for many years by respiratory physicians, but always relegated to the specialty and never expanded to other areas, including our areas of cardiovascular medicine. Sleep apnea syndrome is a condition whereby during night we have a repeated recurrence of either apneas, basically lack of breathing during night for a few seconds, or hypopnea of reduced oxygenation, which leads obviously to disrupted sleep. Hypoxia, a reduction in oxygen in your blood, and very often excessive daytime sleepiness with consequences in your daily life, including the driving risks and the risk of operating important risky machinery for occupational groups. But more importantly, obstructive sleep apnea syndrome is a powerful risk factor for the development of hypertension and cardiovascular disease. And the beauty of it is that once that has been diagnosed, there are effective ways of reducing the consequences and the symptoms of obstructive sleep apnea syndrome, and that by applying what we call continuous pressure airway treatment by or CPAP, which is a condition where you pump high pressure air through your airways so to allow them not to collapse during night. And that collapsing of soft tissues in the airways is usually the cause of having your apneas. So in terms of practicalities, it would be important for consultations to try and investigate the presence of disturbances of sleep of quantity and quality, either by addressing the lifestyle factors that individuals can correct by protecting their sleeping time, or if necessary, the investigations of other risk factor for sleep apnea syndrome, which very often is associated with high collar size, obesity, or hypertension, and refer it to the appropriate specialist.
My name is Kennedy Cruikshank. I'm Professor of Cardiovascular Medicine and Diabetes at King's College London at Guy's and St Thomas's Hospitals. My first topic is what to do about blood pressure and diabetes. And this has become a real focus of activity. Diabetes needs better control of blood pressure more than any other discipline. But recent studies have shown that lowering the blood pressure too far isn't really associated with very much benefit beyond extra stroke control. So the best way to lower blood pressure and diabetes is combination therapy. It can be given in one tablet, and these usually include a calcium antagonist, an ACE inhibitor, or a A2 receptor blocker, and indeed a diuretic. And people underuse diuretics in diabetes because they are worried about the blood glucose change. The better blood pressure control adds much better risk prevention than a very tiny change in blood glucose.